I will talk about FMG Anesthesia June 2022 questions. Now, there were 7-8 questions and there were a few very good questions which was asked this FMG entrance exam. So, first question was, before laparoscopic surgery, what advice should be given to the patient by surgeon for NP or anesthesiologist? In question they wrote surgeon, so I have copied, but the order is given by anesthesiologist. Should be given by anesthesiologist for NPO, for the NPO, that is nil per oral, right? So options were NPO 8 hours before OT, NPO 2 hours before OT, NPO 24 hours before OT, and no need for NPO in laparoscopic surgery. The first thing I want to clarify, any elective surgery, let's say whether I'm planning to give GA or regional, the NPO order is same and NPO order is must. So before elective surgery, we have to keep the patient NPO. Now, for adult, what are the NPO guidelines? 3 important timelines we have to remember. For adult, 2 hours NPO is required for clear fluid like water, like coconut water, or like your apple juice without particulate. 6 hours NPO. 6 hours NPO we require for semi-solid or liquid. So semi-solid or liquid like dal khichdi, right? Dal khichdi or like curd rice, anything of that sort, right? And 8 hours NPO for full fatty meal, okay? For pediatric, just one more timeline is added. 2 hours NPO for clear fluid, 4 hours NPO for breast milk. If child is exclusively on breastfeed, we ask the mother to give the last breastfeed 4 hours prior to surgery. And 6 hours NPO for semi-solid, liquid or any outside milk or formula feed, anything. 8 hours NPO if the child is taking full meal. 8 hours NPO for full fatty meal. Okay, for full fatty meal, NPO is for 8 hours always, because fat takes more time to go out of the GI system, stomach. So we have to keep it in mind. Okay. So as I told you, the fasting recommendation, clear fluid 2 hours, breast milk 4 hours, for infant and non-human milks, infant formula, and for non-human milk 6 hours, and light meal 6 hours, and for fried fatty food 8 hours. 8 hours NPO is required. Okay. So in this question, if 6 hours was there in the option, see, food is not specified in the question. They only ask that what order should be given, how many hours NPO prior to surgery. If food is not specified, it is not clearly mentioned in the question type of food, always think as light meal which we advise prior to surgery. So answer should be 6 hours, but 6 hours was not in the option. So I would go for answer as 8 hours. Okay, 8 hours was previously even for the light meals, but it has been nowadays changed to 6 hours, the recommendation, and 8 hours has been reserved for fried foods, fatty meals, right? So, but if 6 hours is not in the option, we go for 8 hours as an answer. So remember, NPO is required for every elective patient. NPO is must for any elective surgery. 24 hours NPO we never do, and 2 hours is only for clear fluid. Okay. So this was the first question. Now coming on the second question. Which of the following inhalational anesthetic agent requires a special vaporizer? Special vaporizer. And the option is desflurane, sevoflurane, isoflurane and halothane. Now vaporizer, it is equipment which is used for storage and delivery of inhalational agent. Storage and delivery of inhalational agent. Okay. These inhalational agent, the potent one, desflurane, sevoflurane, isoflurane, halothane, they are liquid at room temperature. These are liquid at room temperature. So we pour it in vaporizer, and as you can see, this is a vaporizer. We pour it in a vaporizer. Vaporizer change the liquid into vapor and then add to other gases. So we need to know the boiling point of different agent to use it in vaporizer. Now, most of the agent except desflurane, they have more or less same boiling point. Boiling point is 50 plus minus 2 degrees Celsius for these agents. Desflurane, boiling point is 23 degrees Celsius. So, desflurane, two important physical properties makes it different from other inhalational agent, right? One, it has a very high saturated vapor pressure. So, SVP stands for saturated vapor pressure, right? Okay, so it has a very high SVP, and other, it has a very low boiling point. At room temperature, it will intermittently boil and it could result in large fluctuation in the delivery of these gases. So that's why we cannot use it by a conventional vaporizer. It requires a special vaporizer. So two property, very high vapor pressure and very low boiling point, requires a special vaporizer. First special vaporizer which was used for desflurane was Tech 6 vaporizer. So Tech 6 is a special vaporizer which is used for desflurane. See guys, Tech system of the vaporizer, Tech 2, Tech 3, Tech 4, Tech 5, Tech 6, and latest one is Tech 7. All of them except Tech 6 can be used for any agent. Tech 6 was specially made for desflurane. So from Tech 6 vaporizer, only desflurane can be delivered. And this is the image of Tech 6 vaporizer, right? Desflurane has a blue color code, and its vaporizer is different from the conventional vaporizer. Okay. Now coming on, so and other agent have same. So if you see there are 4 vaporizer, and here in this question only I will tell you about the color coding of the agent. These 3, the vaporizer is same, the only difference is the color coding. So this yellow color code is for sevoflurane. This purple color code is for isoflurane, and this red color code is for halothane. And blue is for desflurane. Okay, blue is for desflurane. This is desflurane. Okay, now any image of any vaporizer can be given and they can ask you to recognize the vaporizer. Desflurane vaporizer is different from all the other vaporizer. Desflurane requires a special vaporizing technology, right? Cannot be used by a conventional vaporizer. Okay, now coming on the next question. Next question was again from the topic so commonly asked in exams, CPR. You are somewhere and you saw a guy collapse. Matlab you are out of hospital scenario. And you started CPR and soon the advanced cardiac life support came. See, when you come across a victim in cardiac arrest, you start basic life support, right? Basic life support does not require any equipment except automated external defibrillator. Basic life support can be given by layperson. So it is very basic. Eventually, the advanced, you have already called for help. Basic life support, the first step is call for help. Eventually, the hospital personnel come over and they take over the patient. That's called advanced cardiac life support. So once the ACLS people came, what will you do next? This is the question. First option, hand over patient to them and leave. Well, ask them to apply the paddles while you continue CPR. Stop CPR and let them apply paddles. Continue 5 rounds of CPR and then use the defibrillator. Guys, remember some basic important things about CPR, especially basic life support. For basic life support, you have to remember this chart crystal clear, in a crystal clear way. First thing, when you come across a victim, you verify the scene safety, right? First thing, you verify the scene safety. Once the scene is safe, out of hospital, lot of time scene may not be safe. So first you have to make the scene safe. Once the scene is safe, then you call for help. You call for help, activate the emergency. And then you get AED, automated external defibrillator, as soon as possible. Well, if you don't have AED, you have already activated the emergency, they will come with AED. Meanwhile, what do? You assess the breathing and the pulse. Well, normally we should assess them simultaneously. Pulse can be felt and breathing can be seen by the movement of chest. So both the work, feeling and seeing, can be performed simultaneously. So we feel for the pulse and simultaneously keep our eye on the movement of the chest to check for breathing. If both breathing and the pulse is present, we monitor the patient. We don't leave the unresponsive patient. we make the patient in recovery position, that is lateral position. We change recovery position so that the patient should not aspirate, and wait for the emergency to come. And if the patient is not breathing, patient is in apnea or gasping like this, this is not normal breathing, this is gasping, and it is considered as no normal breathing present. But pulse is there. If pulse is there, breathing is absent, it is respiratory arrest, not cardiac arrest. Respiratory arrest. In respiratory arrest, we provide the rescue breath, 1 breath every 6 seconds, 10 breath in a minute. And we check pulse every 2 minutes. If no pulse, start CPR, right? Okay. If no breathing, no pulse, patient is in cardiac arrest. Patient is in cardiac arrest. Okay. When patient is in cardiac arrest, we start with high quality chest compression. So we start cardiopulmonary resuscitation. We perform 30 compression and 2 breath. High quality chest compression. What are the features? In a second I will tell you. When the AED arrives, that is emergency system comes, AED arrives, let's say ACLS people came with a manual defibrillator or automated external defibrillator. As soon as they come, we have to ask them to attach the pads of the defibrillator, and while so as the emergency system comes with a manual defibrillator or with an automated external defibrillator, as soon as they come, we have to ask them to attach the pads of the defibrillator. Meanwhile, we continue doing the chest compression. Well, there should be minimum gap in chest compression, right? We should not leave the chest compression. That is the most important step. But once the defibrillator comes, we have to attach the paddle also as quickly as possible. So we ask them to attach the paddle. Once they have attached the pads, then we leave the patient so that automated external defibrillator will recognize the rhythm, or if it is a manual defibrillator, we stop compression to see what is the rhythm of cardiac arrest. If the rhythm is shockable rhythm, we give the shock immediately. It is said that if the rhythm is shockable, if you give the shock immediately, chances of revival is best. We give the shock and then resume the CPR immediately for next 2 minutes. And after 2 minutes, again stop the compression, see the rhythm and accordingly act. If it is non-shockable, right? Non-shockable rhythm. It is non-shockable rhythm, right? Then we don't give shock. No shock. Here, non-shockable, no shock. We resume CPR immediately for next 2 minutes, right? And after 2 minutes, again we stop and check the rhythm. Okay, we go on doing this. This is basic life support, right? So, as soon as the advanced cardiac life support team arrives, what do? We ask them to apply the paddles while we continue doing the CPR. Once the paddle is applied, then only we stop CPR. Okay? Okay. Now, there are some important things which we need to know about the quality of CPR when we are doing CPR. What is the criteria for high quality CPR? High quality CPR. Now, remember, for high quality CPR, compression should comprises maximum time for resuscitation. Chest compression fraction, the proportion of time during management of cardiac arrest we are giving to chest compression. The proportion of time that chest compression are performed should be more than 80%. It should be more than 80%. Chest compression rate. Chest compression rate should be between 100 to 120 compression per minute. Chest compression depth. It should be more than 5 centimeter in adult, that is more than 1/3 of the anterior posterior dimension of child and infants. We should allow the complete recoil. We should not compress and again compress. We should allow the complete recoil. And ventilation should be just adequate. We should not over-ventilate. If you will over-ventilate, patient can aspirate and hemodynamic imbalance can happen. So less than 10 breath for adult is enough for ventilation. So this is the 5 important points for high quality chest compression or CPR, high quality CPCR. Got it? Okay. So coming on next question, patient went unconscious after giving intercostal nerve block. So patient was given intercostal nerve block and patient became unconscious, diagnosed as local anesthesia, systemic toxicity. What is the management? Okay guys, local anesthetic systemic toxicity. This is kind of very popular topic nowadays. Local anesthetic is given for regional block and it is always given locally. If it gets intravascularly absorbed and if it causes toxicity, organ dysfunction, we call it local anesthetic systemic toxicity. How do we manage it? First of all, let us talk about some of the clinical features of local anesthetic systemic toxicity. So, what are the symptoms, diagnosis and treatment of LAST? Now, symptoms of LAST. Now, what does local anesthetic do? It goes and binds to the sodium channel, and sodium channel are present in central nervous system, on cardiovascular system. So it can go and bind to the sodium channel of the system. So what happens? It goes and bind to the sodium channel of the system and block the sodium channel. So what are the clinical features come? In central nervous system, we get first excitation followed by depression of central nervous system. So CNS more sensitive to local anesthetic systemic toxicity. Remember, mostly first symptoms of local anesthetic systemic toxicity comes on CNS. CNS symptom precedes cardiovascular symptom, thankfully, because CNS symptoms are more manageable. Cardiovascular symptoms are more life-threatening. The last affect the balance between inhibitory and excitatory pathway of CNS. Local anesthetic going to central nervous system disrupts the balance between inhibitory and excitatory. So neurological sign and symptom range from excitation followed by depression. So first, early is patient becomes excited. Suddenly patient will say, doctor, I'm not feeling well. Suddenly, what are you doing? Aggressive behavior for no reason. And then depression. Okay. Now, if it goes, right, it blocks the voltage-gated sodium channel, inhibitory of cortical neurons of CNS. So, excitatory manifestation. So, what are the excitatory manifestation? Seizures, agitation, or loss of consciousness. Now, before these manifestations, some early features also come, which can be asked in exam, early symptoms. Early symptoms can be perioral numbness. Perioral numbness, right? Perioral numbness. Patient complains of metallic taste of tongue and tinnitus. Metallic taste and tinnitus, right? And then it will progress to seizure and all. Okay. Now, if more and more high dose is going, then CNS symptoms sometimes when a lot of high doses, let's say, absorb intravascularly. So CNS symptom may not be seen immediately cardiovascular symptom. Cardiovascular symptom will mask the CNS system. So there is a possibility that without CNS manifestation, cardiovascular symptoms come. Normally, first CNS symptom comes, then cardiovascular. But there are possibility that cardiovascular symptoms can also come first. So cardiovascular toxicity, heart conduction is affected because sodium channel is blocked. So decreased cardiac contractility and vasodilatation, decreased systemic vascular resistance. So ECG changes, etc. can also come. And what will all this result in? All these clinical features will result in what? It can result in hypotension. It can result in ventricular arrhythmia. And it can result in cardiac arrest. Cardiac arrest. So how will I manage? What is the management of LAST? Well, diagnosis should be confirmed and management should be done accordingly. Now, if during the procedure, we should always have high index of suspicion. If during the procedure any symptom is coming and I'm injecting the drug, immediately I have to stop further injection of drug. So immediately at the time of injection, right, the LAST can appear, or it can also appear, let's say, an hour after injection. Slowly the drug absorbed intravascularly, right, delayed also. So always while you give local anesthetic, you monitor the patient, right? Always for 30-45 minutes, you always have to do a careful monitoring, right? Some patient signs of LAST can also come later on, right? So there is always a possibility onset time. Onset time mostly is immediate, can be little delayed and can be more delayed also. So you always should have a high index of suspicion if you have given a regional anesthesia and injected local anesthetic. So how do you manage? How do you manage LAST? For management of LAST, this is the flow chart. Okay. Management is symptom. It's an emergency. So always you call for more people for help. And the management is symptomatic. Okay, management is symptomatic. Whatever symptom is coming, we manage. Okay, if seizure is coming, we give midazolam. If cardiac arrest has happened, we start CPR. Plus, we give a rescue therapy. Rescue therapy. What is the rescue therapy in last? Rescue therapy is 20% intralipid emulsion. 20% intralipid emulsion. Now, 1.5 ml per kg, right, of 20% intralipid is injected, followed by 0.25 ml per kg per minute infusion. Okay, if patient is not improving, we can further increase the dose. Okay, and we monitor the patient and start this. What happens? Why do we give 20% intralipid emulsion? Now, 20% intralipid emulsion, or it is also called that intravenous lipid emulsion is also called lipid resuscitation therapy. It is also called lipid resuscitation therapy. What this lipid does? It absorbs the drug, the local anesthetic from intravascular space, and it absorbs it and does not let it go to the sodium channel of brain and heart any further. Plus, lipid causes little bit of increase in blood pressure. Plus, it has something cardiotonic effect also. So, it increases the cardiac contractility also. So, we call it lipid resuscitation therapy is what we practice in last. Now, there are 3 pillars of managing last. 3 pillars for managing last, which consist of seizure management if patient has seizure. Right? If patients have seizure, then seizure management in which midazolam is the first drug. Then ACLS, if patient has gone into cardiac arrest, ACLS, that is, we do resuscitation. If patient has gone into cardiac arrest. So, cardiac arrest, we do resuscitation. Plus, what rescue therapy we give? We start 20% lipid emulsion. So, lipid rescue therapy. So, this is called 3 pillars of last treatment. Okay. So, in this question, they asked that patient had local anesthetic systemic toxicity. What is the management? 20% intralipid emulsion is the rescue therapy. We do lipid resuscitation. Okay. Now, coming on the next question. Next question, that is, a known case of asthmatic bronchitis reported to hospital with breathlessness, palpitation with oxygen saturation of 88%. Hospital had no ventilator. All of the following can be given to the patient except. Now guys, they are asking management of acute exacerbation of bronchial asthma. So, acute exacerbation of bronchial asthma. So, what do we do in this? Well, the mainstay for managing this is bronchodilator therapy. Options were hydrocortisone, magnesium sulfate, oxygen and leukotriene antagonist. See, mainstay is your bronchodilators, which will dilate the bronchus acutely, and then we take the patient on long-acting bronchodilators also. First we use short-acting repeatedly and then long-acting. But there are some adjuvant drugs also which has some role. So let us see what are the different drugs which we use. In asthmatic bronchitis, we use bronchodilators like the short-acting one, salbutamol, salmeterol, formoterol, and ipratropium should always be added. Right? Ipratropium should always be added. They have a huge role in acute exacerbation. And theophylline, if you are using, you have to be very careful because theophylline can have effect on heart, can cause arrhythmia, and also have to be very careful, see in the patient. So it's not in every patient we add theophylline. Okay. Now they dilate the bronchioles and allow better airflow. So apart from bronchodilators, the next thing, first priority is bronchodilator, next is steroids. Now in steroids we can go for steroid, inhalational steroid, and we can also go for IV steroid, inhalational plus IV combination. So beclomethasone, budesonide, fluticasone, both oral and inhaled. inhaled corticosteroids. What do? They decrease the swelling of airway, they decrease the inflammation of the airway, and they can provide immediate relief. So this is, let's say, one of the mainstay of the therapy. Then we can give some other adjuvant drugs like leukotriene modifiers like montelukast, jafarlukast, gileotans. These drugs can be given. What they do? They stop the chemicals, the release of chemicals, which tightens the respiratory tract. So they can be used. Montelukast, etc., stop the release of inflammatory mediators, which can cause bronchoconstriction. So they can be given. Antibiotics can be used. It's not indicated in every patient, but it can be used in case any infection is suspected. So active bacterial infection, we can start antibiotic, and always we should attach oxygen through a oxygen delivering device. So we can use face mask or we can use Venturi mask, and we can give oxygen therapy to these patients. Okay. Now, in the question, what was the option? Hydrocod. It's one of the mainstay of the therapy. Magnesium sulfate. Well, magnesium sulfate, some role has been, let's say, described in some books, that magnesium sulfate can cause bronchodilation, can inhibit the release of calcium, which causes bronchoconstriction. So it can reverse the bronchoconstriction caused by calcium. So calcium-mediated bronchoconstriction can be counteracted by magnesium sulfate. Plus, it has many additional roles. So some books write that magnesium sulfate can be given, but it is not the mainstay of the therapy, right? It is not something which is practiced very commonly, but magnesium sulfate can also be used. Oxygen, we always attach because patient has less of the saturation. Leukotriene antagonist is used, and Harrison writes it that as I told you also, leukotriene antagonist is used. It stops the let's say release of the inflammatory mediator which causes bronchoconstriction. So all four can be used. So what is the least important, and what should be the answer? Answer should be magnesium sulfate, right? So though some places they use it, but it is not the main line of therapy, and role has been not completely cleared, right? So that's why the answer would be magnesium sulfate. Okay. Now coming on, next question. A patient is planned for surgery. Which of the following is accurate regarding hair removal prior to surgery? Now options were hair removal before surgery by razor, hair removal before surgery by clipper, hair removal in OT by razor, and tell the patient to remove the hair and come. Now all these options. So what is the answer? Recommendations, we have to follow the evidence-based guideline and recommendation for the hair removal prior to surgery. So NICE guideline, WHO guideline, right? What do they say? And most of the other guideline, especially NICE guideline and the WHO guideline, they recommend hair should not be removed until and unless it is absolutely needed, right? If it is interfering with the surgical incision site, then only hair is removed. Otherwise, hair is not removed. So hair is only removed if it is absolutely required. Then we have to use clippers. We don't use razors nowadays. So clippers should be used. So whether hair should be removed or not, it depends upon whether surgical site is incision is getting interfered with hair. So what is the equipment used to remove the hair? Clipper, not the razor. And what is the time? What is the best time to get the hair removed? The best time to get the hair removed, the NICE guideline says, just before shifting the patient to the surgery, right? On the day of surgery, just before shifting the patient to the OT. So it should be performed on the day of surgery. So what is the best time for getting the hair removed? The NICE guideline says that it should be performed on the day of surgery. That is, just shifting the patient prior to surgery. Just shifting the patient to the OT, right? We should get it removed. If we get it removed long time before, then there is a risk of bacterial contamination, and razor seems to cause more bacterial contamination by causing an abrasion than other devices. Okay, so remember that. What is the best time for the patient to get the hair removed? Hair removal before surgery by clipper. B should be the answer. Got it? Okay. Now coming on the last question. A patient came to emergency department with palpitation and shortness of breath. In ECG, there was an absent P wave. Absent P wave. And pulse was irregularly irregular. Irregularly irregular. Okay? The most probable condition. The most probable cause of this. Okay? Now, absent P wave. No P wave. Pulse is irregularly irregular. The answer has to be atrial fibrillation. It is pathognomonic of atrial fibrillation, right? So let us talk about tachyarrhythmia. Now tachyarrhythmia, if the pulse is irregular, it's atrial fibrillation. Usually the correct answer is atrial fibrillation. In this, P wave is replaced by fibrillating wave. Fibrillating wave. It is replaced by fibrillating wave. And what happens? Atria is contracting, contracting in very indiscriminate manner, right? So all the atrial contraction is not getting transmitted to the ventricles. So what happens? The pulse becomes irregularly irregular, right? And regular ones are sinus tachycardia. Regular ones are sinus tachycardia, atrial flutter, atrial tachycardia with ectopic P, and PSVT. PSVT, okay? Paroxysmal supraventricular tachycardia. So these are, for narrow complex tachycardia, these are which have a regular rhythm. And atrial fibrillation always will have irregular rhythm. So in the question, if the rhythm is irregularly irregular, you always have to go for answer atrial fibrillation. In flutter also, P wave is replaced by flutter waves, right? But the rhythm is regular, okay? In PSVT, we will not see any P waves. P wave would be masked, let's say, hidden in QRS complex, okay? So let us talk about stable, how do we manage stable narrow complex tachycardia? Regular or irregular rhythm? If it is regular rhythm, then we go for, most probably it will be PSVT or atrial flutter. In this case, we go for vagal maneuver. How do we do vagal maneuver? We first palpate the carotid artery for absence of any bruit or something, and then with our one finger, one side only we do it. We palpate for the carotid sinus and we do a carotid sinus massage. We do a carotid sinus massage. Okay, this is called vagal maneuver. Now 25% of PSVT is converted into normal sinus rhythm by vagal maneuver. And if it is not converting, we give adenosine. Adenosine, what is the dose? 6 milligram rapid IV bolus, right? And we repeat 8 to 12 milligram if first dose does not convert it. Now 75% of PSVT will be converted by your adenosine, okay? So if it converts into normal sinus rhythm, we'll just monitor. If it does not convert, then it is not PSVT, it will be atrial flutter. Now atrial flutter, only the rate we have to control by giving beta blocker or calcium channel blocker. We just have to control the rate. If it is irregular, then as I told you, it is atrial fibrillation. In atrial fibrillation, a lot of patient is compatible with atrial fibrillation. We have to see what is the cause of fibrillation, we have to treat the cause. Well, if I have to treat the fibrillation, we don't treat it, we rather just control the rate in emergency. So by giving beta blocker or calcium channel blocker, we control the rate. This is how we manage atrial fibrillation, okay? So for atrial fibrillation, always remember irregularly irregular, right? So let me revise the question once again very quickly. A patient came with to emergency department with palpitation and shortness of breath, that is symptoms, and in ECG absent of P wave, and pulse was irregularly irregular. What is the most probable cause? Answer is atrial fibrillation, right? Then next question, that a patient planned for surgery, which of the following is accurate regarding hair removal prior to surgery? It has to be removed by clipper just before shifting the patient to the surgery. That is the B option. Then the next question, that a known case of asthmatic bronchitis came with breathlessness and desaturation and palpitation. Now, what are the immediate management we have to do? All can be done for immediate management except. So answer would be magnesium sulfate, not, let's say, confirmed role of magnesium sulfate has been proven. Okay. Then management of LAST. The question was on management of LAST. Patient went unconscious after giving block and diagnosed with LAST, what is the management? Answer is 20% intralipid emulsion. Okay. Then what is the, let's say we see the guy collapse and we start CPR and soon ACLS team comes over, what do? We ask them to apply the pads and we continue with CPR. So this is the correct answer. And next question, which of the inhalational anesthetic agent uses special vaporizer? Answer is desflurane, right? This uses special vaporizer. Then the first question was on fasting recommendation. What is the correct fasting recommendation for a patient electively posted for laparoscopic surgery? Answer is NPO for 8 hours before operation theatre. Okay, so these were the questions. Thank you.